Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. Hey, welcome to KIMEcast. Tony Mikla, Russ Dunning. Hey, so let's talk about, like, if you're new to the profession and you're coming in as a PT. We talk a lot about on the podcast, great treatment strategies, intervention strategies, some different mindset things, development. So we always get the question as far as if I'm new to the profession, how do I get into sports medicine, and what are some of the steps to take, et cetera. So I'll just kick us off and say the first thing that we look for in a person is really two qualities. I think we've said this already, is that we look for the person's ability to communicate. So are they able to communicate, have a conversation? Are they comfortable talking to adults? That leads to them being more confident, obviously, which is very, very important, because if you can't get the patient to trust you and to engage, then no matter how good you are with your content or knowledge, they're not going to do it. So that's number one. Number two would be your passion. If you're passionate about the field and about helping people more than anything, if you're passionate about helping the person, then we know that when that person in front of you states they have a problem and they can't do a certain activity, you are then going to be motivated, because you're passionate about helping them, to solve the problem. It means you're going to want to do some research. You're going to want to read. You're going to want to get educated. You want to gain knowledge, because you don't want to come back to that next appointment with that person and not have a solution. So if you're motivated to get the knowledge and deliver the knowledge, and you can communicate in a clear way, we know that you have the talent to be outstanding in this profession and really move the needle, really have some impact on people. So once we've identified that, we really feel that we can help develop the skill set necessary to be great at sports medicine. So we do this through a series of training, and there's quite a process here. So we have very onboarding process where you come in and you learn the background methodologies and philosophies that we use. That's taught mostly through an online platform. And then we move into workshops. So we have workshop number one, which Russ teaches workshop number one, which is mostly getting comfortable in the system.
Yep. So we teach evaluation retention. So we think the most important session that anyone ever has is the evaluation. The evaluation means that you learn the story, you assess the limiting factor, what's the key thing or things that are holding them back from any kind of progression or getting themselves out of pain, and then developing a strategy and a plan. And a big part of that is to teach them all the elements. Why does that limiting factor matter for their life? Because we might say, well, it's easy. Your hip internal rotation is 10 degrees. On your other side, it's 25. That's why you hurt. And that's not good enough, because most people will say, prove it. I've had this for 20 years. Why does that matter? Why does it matter?
Yeah.
And so if you can't tell the story of biomechanics, you don't connect. You don't help connect that person to what's really going on. And if they don't understand it, if they don't leave having an understanding of why they hurt, then you missed the mark. You weren't able to simplify it to a credible, trustworthy story that makes sense to them, and that's what they're going to remember. They're going to remember the emotional trust. Yep. They might not remember the details of the story, but they're going to remember that this makes sense.
Exactly.
It might take a few
times. So you use like a range of motion metric or a muscle metric to measure the data, to say, like, okay, here's the number. But then you have to put that into a story or into a larger game. Like, how does this impact your function? How does it impact your movement? And so we use different movement maps. Like, we'll use a fascial movement map or a fascial anatomy map. We use Thomas Meyer's strategy here to identify pathways and synergistic muscles and muscles that work as a team. Because at the end of the day, it's about how well does the person move as a unit. Not do they do things biomechanically perfectly, but are they able to generate force through the ground? Are they able to transfer force to their joints effectively? And then the other map we would use would be the joint-by-joint approach that Mike Boyle and Greg Cook originally wrote. And we've modified that a little bit. We have some variations there that we utilize. However, that concept of how do we use these joints, how do they move, how does the body, alternate in its joint sequence, I think is really, really critical. It totally changed my career and the speed at which I could look at somebody objectively and have a better intervention plan or a whole story. Why is this joint stiff? Well, maybe because this one's very hypermobile, and the balance of the two leads to normalcy. And that might be okay. But you got two stiff ones in a row, then we've got problems.
These two models become very important we spoke about razors at a prior podcast, and these would, I think, kind of qualify for razors of how do we look at it.
Yeah,
so the reason why it's a razor, which simplifies a principle that's a bit counterintuitive. The fascial system is to some degree a razor, like understanding fascial lines and fascial line anatomy, is because that concept comes down to the biomechanical term of intensegrity. So you're getting tension through the integrity of the musculoskeletal system. The key part is the skeletal system is pushing outward on the connective tissue map glove around your whole body. And so it's not so much that gravity is weighing us down, it's our own connective tissue forces are weighing us down. And that's the essence of understanding the fascial lines. And then going back to the joint by joint approach, that's a tendency, which tendency does a certain region of the body have just because of its biomechanical makeup. So those are two key principles that if you understand those principles, it helps guide you to navigate the algorithm of the body.
Yeah, 100%. Now, people always ask, so what do I do? How do I prepare for this? So Gray Cook has been a friend of mine and a mentor of mine from the beginning. I think his stuff is fantastic. So I can't say don't take the FMS. I'd say FMS, SFMA are great tools. I know they're getting a little bit older now, but they're just really great models, and the way of thinking behind them is really productive. We teach them as part of our workshop series informally because it's so critical from a thought process. So if that's something you want to engage in, you can certainly do that, and I highly recommend those. Thomas Meyer's book is probably adequate for you. You probably don't have to go to the course, in my opinion, but I think if you can read the book and take a look at if you just look at the pictures, frankly, which is the best part, you just look at the pictures, you should kind of get it. You start thinking about, okay, what movements do those muscles align with? And once you maybe watch a video on YouTube of Myers talking about his fascial lines concept, it should make a lot of sense to you. And really, then you can start to see movement as a global effort, and you'll start to realize why things are either tight, loose, weak, whatever you want to describe them as, and why there's synergies in that development. All right, so then we move on to some intervention they practice, and then they get in the clinic and they're working. Part of workshop number 1 is also the basics around how to document, how to do those things, because it's really critical as well. The documentation is right, that it's correct, that it's timely, because that sets you up again for this, getting the authorization, getting the approval, so that you can continue the treatment, right? And some of you might do cash pay, and that's totally fine. I think you should still document the same way because it helps you clarify your thoughts. So what was the limiting factor you identified? As Russ said, document that clearly, set a clear goal, come back, readdress it, reassess it next time. Every visit we're reassessing. Did it change? Did it make any improvement? You can get down to every intervention. Did it change to make an improvement? Just make sure you look bigger than the really small details, right? So just looking at one joint doesn't tell the whole story. When you look at change, look at something bigger. All right, so workshop number 2.
Oh yeah, this was the concept of workshop number 2 was kind of teach people how to be a cook through good recipes, knowing that principles guide the most elite level thought. You need some recipes to really kind of get the ball rolling, get traction. So we give some not so basic, but fairly progressive recipes for the 3 regions of the body, the upper and lower, and then the spine. And we tell the tale of starting from a level 1 progression all the way to a level 5 progression from using the continuum. The rubric of the performance rehab continuum is going from a space of inflammatory pain, cutting that inflammatory pain, going into motion, improving stability that then gives you to strength, enhancing strength to then starting to operate the body with some speed, elevating speed to get to some more power, and ultimately into that practice or performance setting. And so using the continuum and having some basic recipes of how to go through tissue reset, basic exercise, and then progress to something that looks like it pretty advanced. And laying out, so it's very exercise heavy. Hey, let's go through a lot of exercise. Let's find out where that exercise fits. Is it more in the reestablishment of motor control and stability? Is it more the enhancement of strength? And kind of going through that rubric. So it's very much a regional focus of basic but very progressive recipes that work for the majority of cases. Yeah.
Well, we have tools here too. So like I said, use the continuum tool. We developed a booklet system where each patient has a booklet that has a continuum and mark where they're at in the continuum and then mark goals as to where they're going and how long it might take to get there. So using that type of criteria, the exercise matrix we've developed is great for this as well. As like, all right, if you start here, this would likely be your next few steps. If you start here, these might be your next few steps. So obviously part of the evaluation process is to determine where you're at in the continuum, where you're at in the matrix, where you need to start, and then the next steps give you an outline. So it teaches the PT how to use that tool. So they have some guidance. So we're more of a recipe fan, and knowing the recipes have variance based on environment, goals, how ripe the fruit was. So how old was the injury? How new was the injury? How old's the person? How young is the person? Those types of things. You might be able to go a little faster with the fast adapter, a little slower with the slow adapter, et cetera. But you get the idea. So we're not a big protocol. Hey, you don't have to follow this protocol except post-operatively. You have to be very, very careful. But yet, if you understand healing timeframes and how tissue adapts, then the protocols make perfect sense. If you're not paying attention to those things, then the protocols are great tools. So I did use a great protocol book when I first started, which was really helpful just to wrap my head around how fast, how aggressive can I be, how much can I load tissue, because you don't really understand that in the beginning. So I think those are good tools to have. I think, Kevin Wilk, Reinhold, those guys have really wrote the book on those types of protocols post-operatively, and I think they're great. I used them proficiently when I was younger, and now it's just common practice for me, and it become best practice, so it's not something I reference a lot. But as you start to understand tissue adaptation better, you start to see how people load better, you start to see how they change, you can figure that out as you go, and as you become more expertise with your clinician skills, that's something you can appreciate.
To say it in a slightly different way, these recipes are a very loose protocol that's based off the dysfunction, whereas many of us are used to a protocol for a meniscus protocol or a UCL protocol. And that protocol is really just trying to understand how does a movement affect the exact repair site. But if every person that has a post-operative patient or has a very distinct diagnosis and is given a protocol, that protocol is not custom to their dysfunctions, because I have yet to have a doctor name one. Dr. Herman in Sacramento does a phenomenal job at identifying dysfunctions. But most doctors don't really have the model to actually say, all right, let's go through a movement algorithm. I'm going to find out why you have an issue. Most doctors are more in the camp of let's get a clean diagnosis and diagnose the state of that tissue, not why it came to be. So if you don't have any kind of dysfunction, you have to find that out. And that gives you a layer of a protocol progression that you need to do to improve that person's dysfunction despite the state of the tissue. Say the Achilles is torn, or the ligament is torn, or the ligament got reconstructed. So if ever you're working on a post-operative or a diagnosis-specific protocol, you then have the homework of doing another protocol. You have to understand why that happened and what issues do they have that will further increase risk of it happening again, irrelevant of how good you follow the diagnosis protocol.
Yeah, 100%. And that's so true. I'd say that, especially if it's a non-traumatic injury, or even if it was traumatic, maybe what happened? Did they get hit by somebody else, or were they skiing and they fell down the hill, and caught the wrong edge or hit a rock or something? There's always a movement pattern behind the dysfunction. Mm-hmm. And this, kind of takes steps beyond the conversation here, but just for reference again, I can't emphasize enough that when you get someone back and you're rehabbing them back to whatever functional activity it is, watch them do it. You have to watch them do it. So if it's running, you have to watch them run. If it's throwing a ball, watch them throw it. If it's swinging a bat, whatever, watch them do at least a few reps. And when you get them back into a fairly healthy state where they can execute that pattern, what they consider to be normal, almost everything will become clear to you. Like in a heartbeat, you'd be like, oh, that's why your leg hurts. Mm-hmm. Every time you swing the bat, that knee dives in and you're really pivoting super hard. Like, why do you have all your weight on that position? Like, why are you using the strategy you're utilizing? Mm-hmm. And they might say, well, I've been coached to do that, or maybe I had no idea I was doing that, or maybe they say, I found that if I do that, really good things happen, Like Tiger Woods could say that I blew out my left ACL because I rotate so hard through the ball, I crush it. Hey, if it's worth it to you, that may be a reasonable choice. Because that's exactly why he hits the ball so hard and so aggressive as a ball striker. That'd be my look at him and say, that's probably what happened with his back and with his knee, is that he hit it so hard now, which is a fair trade when you have the amount of success he had for the period of time he had. Just, I don't know Tiger, so I'm just ballparking there, but just when I look at his movement, that's what I see, and like that increases the risk for sure. And so you would see that with some kid throwing. You watch the athlete throw a ball, you see what happens with the elbow right away or with the shoulder, and like, oh, that's likely the triggering factor. Yeah. So you could have the greatest, shoulder exercise routine ever, where you get it super strong, you get it super mobile, you're killing it, everything's amazing. But then they go back and they have the terrible mechanics, or they even have one problem with their mechanics that's setting them up for failure.
Yeah.
You're going to fail.
Or they have a poor energy system in their legs, and as soon as they're on pitch number 65, all those wonderful mechanics that you talked about with, say, thoracic rotation go out the door.
Done.
Because they're fatigued. So really, I think all this is really, our job never stops. If you ever have a boring session, you just stop thinking. The person can be better. You just weren't able to help them.
Yeah. Well, on that note, we have a student right now who's finishing up a rotation with us, and she's at a previous place, and she's really losing some energy and excitement for the profession, which, we hear all too often, and it troubles me that way. I think it's so unnecessary. But one of the objectives that she had from her CI was to discharge 2 patients a day. And that was the objective, period, though. Not like, if it's due to discharge them, by all means do so, But if the person, just because they're out of pain or just because they could do a simple task, I don't think should justify a discharge at all. You're just starting, the potential of improvement of movement and getting them back to maybe an independent life or a higher level of living that they might want. If we don't showcase that that's possible in our profession, and we don't help people bridge that gap, then we're always going to be pushed back to you're just physical therapy. You're just doing the basics. It's just range of motion. It's just pain relief. It's for grandma, and that's it.
Yep.
And if that's what you want the profession to be, then those types of goals we'll keep it right there.
We have to ask bigger questions. Why? Oh, I want to walk without pain. Why? Because I want to be more active. Why? Because I want to enjoy time with my kids and my grandkids and keep doing it until I'm 100 years old. Let's do that. And then if that's the vision, then are we done after 2.5 months? Or do we have bigger fish to fry? Do we have better things to do? Do we have more to gain from the body to enhance their performance and enhance life?
100%. Okay, so then after workshop 2, we move into a workshop 3 strategy. Workshop 3 is a bit drawn out, so it's a multiple phase strategy of workshops, and they're focused very, very specifically on high level, high performance. So they might be topics like advanced programming. There might be topics like the throwing athlete, the overhead athlete. There might be topics around sprinting and change of direction and deceleration. It might be topics around high-level analysis of using force plate data and how that correlates to both performance as well as injury risk, and dissecting those pieces of data out, looking through specific cases, discussing those at a high level. It could be around nutrition and the impacts nutrition has on tissue healing and other factors of tissue healing, of how that tissue adapts and heals and progresses over time. So these are all segments that we do. We do them over the course of the year. So there might be anywhere from 6 to 8 sessions. And this is an ongoing development phase for us because it's always about what's new, what's on the bleeding edge, not so far forward to hey, what's out there that's cool, let's be aware of that, but let's not jump on the bandwagon either. Let's understand what it is and ask, how does that apply to our patients? How does that apply to the model? And then is that something we can use? Is that something we're missing in the model that can help enhance our outcomes for our patients? So the phase 3 is a developmental process that's ever ongoing and ever evolving based on new technology, new science, new practitioners bringing new ideas.
I think this part is so critical, a truly deep dive from a first principle standpoint. And, when I watch a lot of key influencers on social media, I tend to follow more of X.com largely because people have deep dives that are words, less of video and more about a deeper dive of words. And I'm finding a lot of influencers really pushing hard the expensive modalities, whether it's really expensive supplements like M&M and NAD+, or injection therapies and biologics that have definitely some efficacy, but they're definitely more costly. And then there's the peptide injections and using some other fancier version, or it could be even like red light therapy, hyperbaric chamber, and cold plunge. So it seems there's this massive push for all of these, frankly, I think pretty costly, if not by time, by a lot of people involved. Some can be $100,000, some can be $2,000 for a home purchase, but it's a lot of money to try and enhance the regeneration of the human when we have such a phenomenal ability with just good food and appropriate exercise. So this deep dive of phase 3 is really trying to people really understand and unlock the human potential that's at your fingertips and relatively free. Not to say that we cost something, but on the grand scheme of things, once you learn the stuff that we teach, it's like, now you know this, now we just have to affect your psyche so that you actually live it, adopt it, and make it into a habit and believe it, rather than, oh yeah, you told me to do that drill and I forgot. But don't worry, I got my injection next week.
Yeah.
You know, does that, I think we're at a crust of that. So phase 3 is really able to be able to just not only talk the talk, walk the walk, but truly do a deep dive to affect a human.
Yeah, I understand what's going to move the needle. That's always a big question. I didn't do that, but I'm going to do this instead. Or I didn't do that, I'm going to do this, this, and this. It's like, what's going to move the needle? What's like the first principles, as you said? What builds the foundation? What builds the base? And if something's missing there, then you can add all the stuff you want. But if you don't do the basics, you said cold plunge. Do you do cold plunge, by the way?
No, I did cold shower for a few times. I thought this is the most stupid thing ever. I did it a few times. I really feel like people needed something to do. And they got a little bored. It's amazing. Now, I do have a few elite level athletes that do it regularly, and they will admit that they do it more for their brain than their body.
Yeah.
And that's I can see there.
This is a conversation we had the other day. What does Russ feel like when his feet hit the ground in the morning? Do you hit the ground like just boom, let's do this? We're already sharp as a tack.
Yeah.
It stays sharp the whole time.
Yeah,
right?
5:45. I'm not really. If you said 5:15, I'm like, okay, but 5:45, I'm there. Cortisol goes to the
sleep solid, and it's time to go.
It's time to go at 5:45.
Yeah. So I think I sleep really well also. But I do like the cold plunge. I don't do it myself. I think it's crazy. But I'm not a cryotherapy guy. I don't think we've tested that and looked at stuff there. I don't think that gets the job done really on like the mass level. Like maybe if you're a really elite athlete and you're looking for this like 100% better, then that could be a fine option.
Well, even the cryo people don't believe in it. That's why they embodied red light, and that's why they're doing like the exercise amidst it. It's like they're trying to throw more at it too, because they realize, you mean this dry cold doesn't change the internal temperature all that much? Correct. Dry does not change the body that much.
So the cold plunge, I think, is really great. It's just, I think it's a tough business model because, I mean, you're having people pay money to come jump in freezing cold water.
Extremely uncomfortable.
It's like the hardest thing to do. Like, I hate cold water. So it's like, to pay money to do that, it's just, holy moly.
Yeah.
Yeah, and to come to the whole thing. But anyway, I just saw like this amazing, like I had an idea, like, because we've talked about having like a recovery studio and stuff, of course, like everybody does, but we've eliminated that idea. But nonetheless, I saw this awesome like cooler. This cooler was like a bathtub. I'm like, holy moly. It was a sporting goods store. It was a hunting cooler. This thing was massive.
Like you put a bear in it.
Easily.
Yeah.
But it'd be perfect for like a cold plunge.
Yeah.
And just as a lid, you know.
See, I could do that because then it's like double dipping. You buy a cow or the next season you just use it.
This is how Russ thinks, is that's an effective tool. I should own one of those.
Dual purpose.
I could use it for multiple things.
Dual purpose.
You can put your kids in it and push us a sled. I mean, there's lots of options.
I mean, I think people do cold when they're trying so hard to heal and regenerate and do things. And they're just like, you know what, I'm going to do everything. When you have a person that's willing to do anything and everything, they do cold plunge. The challenge is, usually I find people, if they're doing a lot of cold plunges, like they're not that far away from either a surgery, a major procedure, major injection.
Yeah, it's a big deal.
That's how hard they're trying.
The hyperbaric chamber is in the same category where they're really trying to move the needle in a certain way, which is great. Great tool. I think the cold plunge is cool. I definitely think mental sharpness is there, and I definitely think there's a recovery. I mean, I've never been in any part of anything that shocks my system as strongly as that. Yeah. Like it's extremely effective. Like I think in random times, we can go on and on about that, but anyways, that was fun.
Well, I will say just a tandem part to it. Plenty of research, especially in like the habit world and psychology world, will say that your grit, determination, the ability the will to endure is a defined quality that we all have. It's like the strength of our muscle. We have the strength of our whatever that
doubt.
part of your brain is. I'm sure Dr. Huberman could like tell me exactly what part of that brain is,
Sure,
because
yeah.
David Goggins is massive.
Yeah.
But whatever we're at, it's a distinct limit. And when we do a cold plunge, you just ate up some of your bandwidth. So if you've got some other stressors and you've got some other things to deal with, you've got some other shit to deal with, if you have 3 kids like I do, why would you ever do that? Because all those other stressors will eat up my bandwidth a ton. So I do think about that a lot. And I think David Goggins, his is insanely high because he's chosen very, very difficult things to do. So I think you could keep choosing difficult things to strengthen that part of your brain. And that's where I think it fits mostly in. As a strengthening tool for your amygdala, or whatever the point is. I don't know the part Dr. Huberman speaks about.
I like that. That's a good idea. I would say that because for that same idea, it's much easier to cold plunge like in a group. Like with the team.
Yeah, you get excited about it.
Yeah, well, I don't know about excited, but at least someone's excited.
Yeah.
And then that helps like me participate.
For sure.
I'm sure the fuck I'm not going to be the one to say, let's all go do this.
Oh, for sure. Oh, just in April.
But if everyone's doing it, like, okay, I guess if I have to, I can do it, right?
I mean, in April, it was like 58 degrees outside. The pool temperature is like 42. And if I go on a Saturday afternoon and say, hey, kids, go take a dive in the pool, no way are they diving into temperature like 49 degrees. But if I invite the whole soccer team over, 9 out of 10 of them will do it because of that. They get the rush. They get the adrenaline. They get like the social... like, I can do this, Yeah. If it's just solo, why would you ever do that?
Yeah. It's a good challenge. It's a good, there's some value to it for sure. I like it.
But that's what phase 3 is all about, is understanding the psyche and to affect a human or to affect a team or to influence a coach.
Yeah. I understand, like, once again, the big picture that in itself, by itself, isn't the only modality that's necessary. There's other factors to be considered for sure. Mm-hmm. So then our kind of final stage of development is far beyond the clinical side. It'd be our phase 4, and phase 4 is a leadership development program that we utilize to develop leaders in our organization to continue to influence and impact people at a greater level. So as this type of leadership development, you're actually starting to look at peers, become a mentor in our organization, working with other providers. Or if you're not a provider, working with other peers in your space, in your entity. And that's an evolving process that has a few steps to it as an overall phase 4 process. But there is kind of a key, 12-week leadership development training cycle that we go through that has a variety of things, from cases to philosophy to application. But we really try to make it as applicable as possible within our system, within our methodology, in our particular case, so that it's transferable. Because I think philosophical leadership training is good in a lot of ways, and a lot of times you have to get there at some point. But if you can't apply those strategies, or they become too gray, because leadership's tough. When you're face to face with a problem, you have to really kind of bear down and then go solve that problem, and you have to figure it out. And it may not be in your repertoire to think about servant leadership in the moment and kind of strategize through all that in your head. You just kind of go. So I think you have to have the philosophy and understand how it works, and then you have to have specific examples of how you would handle this and how you'd manage it. And there's many other levels to understanding the leadership model of when do you have meetings, when not to have meetings. We are very non-meeting oriented as a group. Figure the more we meet, the more confusion often occurs. I read a great thing at one time. I don't know if it was Simon Sinek's Start With Why, but one of those types of books, and it was, if the meeting lasts more than 15 minutes, then it should have been canceled, and don't have a meeting if it could have been solved in an email. So I'm a big fan of that. But we have a meeting structure of what we meet about in the company, why we'd meet, when those meetings are. And then there's individual development, there's mentorship, and all of that stems and funnels out of the leadership training module.
Yeah, it's also, I think a lot of that kind of speaks to the leader within a company, and then how you extend that leadership to outside the walls of your clinic or practice or gym setting. And how do you affect teams? How do you affect doctors? How do you change the lives of coaches at a gym 10 miles away? How do you connect with the Little League baseball team and influence them? Or even like a booster club and try and rally a community around a cause. So it could be something as attending a race, or it could be doing an athlete testing event, which is kind of, we talked about a little bit ago. But the community leaders embodies a very important transformative leader, whereas the internal leader might need more of the, I'd say, like traditional leadership mindset of how how to lead people and guide them through good business practice. There's the other leadership that's really, frankly, quite exciting, and we term community leader, but we teach both.
Absolutely. So from a leadership development standpoint, man, this is like Pandora's box of options. But I think one thing in business that I would highly recommend anyone in our field of the service industry go into it and look at is, we started off reading The E-Myth of Michael Gerber. And when I first read that book, I laughed by the second chapter because I was in an environment where I realized that, like, oh my gosh, like these are all the things they're doing. Like no wonder some of these challenges are present. And in diving deeper, I was like, oh, like I really started to appreciate the system and the methodology of a business and how it needs to be a process-driven type of an entity. And there needs to be structure and why those things exist and how to develop them.
Because Gerber was famous for saying, why would you ever manage people? People are unmanageable.
Yeah, exactly. People are unmanageable, which is so true. So because people change what they want, right? They change what they want. They change their direction. It's impossible. And you should never try to say like, hey, I'm going to dictate you or tell you what to do. Like that's just not in our philosophy at all. So it really aligned with what we believe in, which is that people can achieve great things. And they do really well with some structure and a platform that they can run with and they can then execute. And they can achieve greatness with the proper mentorship, with a proper platform. They can really, really take off. So that's what we've tried to create and astound to. But I think we make a big mistake sometimes in starting a company, and it comes down to what you name it and how you function and how you lead. And, in my opinion, the second you put your name on the building as an individual person, like your last name or something like that, I think that you've really killed the potential of your entire team. Mm-hmm. Because as soon as you're not there anymore, then it's very difficult for that company to survive. It's possible, but it's very, very difficult to overcome that change. And it just becomes a constant, you're working for a person versus working for an entity that believes in something much greater. Mm-hmm. It's always been important to us that the entity is greater than us individually.
It's a very subliminal message that says, this is about me.
It's about me, that I'm the man. And that's not the case. And that shouldn't be the case. That what I hope for in our organization is that I've learned a tremendous amount in my last 20 years. I want to pass that along through these workshops, this development program, to people as fast as I can. So if you can become as good as I am in 2 years, in 5 years, and whatever it takes you, and knock off the 20, then you should do that. And then you're going to be better than me in the next 5. And that's what it should be. That's what I want. So I want for the professions, what we want for the people that we can serve, is that they become better. They should be. They should be better. Mm-hmm. I mean, that's the whole point of working with mentors and people around you, is that you want to continue to improve. And if I'm only as good as the guy that taught me some stuff, but I didn't take that and develop anything better from it, then I think that's a lack of performance as an industry. So I think those are the big concepts on what to do, how to get started. That's what we do in our organization. So I think if you're just starting, look for an organization that has a process or a plan around development or around mentorship. Ask about that. Try to understand that. I know we get that question very, very often, so it's a really common one. And if they don't have a good answer, if it's not relatively clear what the process and sequence is, I can tell you that it won't be clear in the delivery because of how much work it takes to develop that process and sequence. That took us a lot of time and a lot of work to get to a point where that made sense. Mm-hmm. That process made sense for us, made sense for our people, and allowed us to make sure that our clinicians were growing and serving the community at the highest level they could. Mm-hmm. So hope this is helpful for y'all. Thank you guys for listening. If you have any questions, comments, want to add anything, please do so in the comments below. I would look forward to hearing from you.